Uh, Good evening, everyone. Assalamu alaikum wa rahmatullah. And continuation of our preparatory, OSCE preparatory course. Today we will continue on the obstetrics emergency, mainly obstetric emergency. And we will talk about one of the most important and high risk conditions that might occur during the management of the labor ward, which is the emergency cesarean section at the second stage of labor, with the head deeply impacted in the pelvis. How to do it and how to answer a question in the exam, tackling that situation. And on the other half of the session, I'll be talking about obstetric anal sphincter injuries, suturing techniques, care, follow-up, and complications. So my objective of this session is mainly to cover these two main emergencies, and the candidates who are attending this session will be able to answer the station.
بس
and for
معلش على المقاطعة دكتورة ماني، بس أنا ما شايف السلايد متغيرة، ما أعرف باقي الناس زيي ولا متغيرة ليهم.
أنا ما غيرت لسه.
لسه ما غيرتي؟ أوكي طيب سوري.
It's just that this is the introduction. And this is OSCE's workshop last week, 10th September 2025 in Qatar. And I am one of the faculty in the hospital teaching this international workshop as part of critical care and high-risk conference, high-risk pregnancy conference in Doha. This is the one that you are seeing in the back. This is our skill lab. And we are training the candidates. Some of the candidates are coming from different countries from the Gulf region. And we are having the model, and we are having in a wet lab as well. Yani animal training and in a model training, dry and wet lab. So I'll be starting by the second stage cesarean section. The preparation for and the management of the second stage cesarean section, it is once you have been faced this question, you need to at least organize yourself into answering how to answer this question, to divide yourself, to organize yourself, and to put a skeleton. And the skeleton will be like preoperative, preparation, and management, and intraoperative techniques that might reduce the incidence of complications and maternal and fetal morbidity and mortality as well, and the postoperative follow-up and intervention that might decrease as well the complications and the morbidity. Okay? And I want you to put this skeleton for any skills or any question that's about how to reduce the complication of operative complication in the vaginal hysterectomy, in laparoscopy, in tackling ovarian cystectomy, any form of surgery, any form of the procedure that you have been asked to answer the question of how are you going to reduce the incidence of complication, just put a skeleton into three arms, three main arms: preoperative, intraoperative, postoperative. Preoperative, what I need to do. Preoperative, intraoperative, how can I reduce the complication, and postoperative management. So in the second stage cesarean section, the preoperative is the most important part in the preoperative. What do you think? What is the most important one in this? You have the list already. What is the most important one?
Expert senior surgeon.
Any other suggestion?
Consent and address a patient.
والantibiotic.
examination. الassessment للعيانة. examination.
مين قال examination? Who said examination?
خضراء.
خضراء. Examination to confirm the station and think of need for assistance to push or fetal pillow. This is the most important intervention that will reduce the complication, and it might help to reduce the complication and helps you to deliver the impacted head. Because the most important one is examination to confirm station. يعني even if you are not the one who decided for the cesarean section and they call you as being the most senior that there is a second stage cesarean, it is not advisable at all to start doing the cesarean section without performing a vaginal examination, assessing yourself, the station. And not only the station, but also the position. Why the position is important?
To guide the head removal of the baby.
Okay, and how this will be done? يعني شنو to guide?
Flexion to more. I will deliver the head by flexion of the head by non-dominant hand from above.
Rotation.
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 You should avoid the rotation and manipulation, aggressive manipulation. لكن it is very important إنك الhead is not occipito-posterior. ولو بقى occipito-posterior and deeply impacted, you think of other options to deliver the baby. So you have to be يعني vaginal examination in the theater just pre-operative is very, very important to know exactly, to confirm the station and to know the position and the degree of flexion of the head. تمام? And this is the optimum time if you decide either you need assistant to push for you, or if you have the fetal pillow, this is the timing to put a fetal pillow. Okay? The other preoperative measures are the common preoperative measures for any procedure. اللي هي WHO checklist for any operative procedure, high risk consent with the possibility of extension, tears, blood transfusion, and return to the theater as secondary bleeding or hematoma. تمام? Plus bladder injury and bowel injury is a common risks associated with the cesarean section. The one who will be doing the cesarean should be the expert one or the most senior one. أو ما ضروري، ممكن مرات الموست سينيور نفسه ما يكون well expert، تكون the most expert. يكون في واحد not the most senior one لكن يكون expert and you trust him well or her, then you can send them for that cesarean section or do the cesarean section. Anesthesia definitely is very important. You are expecting a prolonged procedure. دائما a second step cesarean is not a cesarean section that can finish in half an hour, 30 minutes to 45 minutes. It is either 1 hour to 1.5 hours. عشان كده you need to tell the anesthesia, they should know that this is a Cat 1 cesarean section and the procedure might be prolonged and the risk of bleeding is there. Catheter is very important and sometimes it will not be draining urine لأنه الhead بيكون impacted to pressing on the bladder, what it prevents أو pulling the bladder up and changing the angle, the vesico-ureteric angle, the vesico-urethral angle, and thus the urine is not draining. So while putting the catheter, you should make sure that the catheter is in situ in the bladder and it is well draining. Antibiotic is very important as the time of the induction of the procedure. Intraoperative, we will talk about the intraoperative techniques, the different techniques. Post-operative care, pain management, thromboprophylaxis, indwelling catheter, HDU or high dependency unit or intermediate care unit admission for observation. What are the techniques that you will do to deliver the impacted head?
طيب, we have 5 technique. First one is push, is pull method. Pull method يعني pull from above. Second is push method. Ask assistant to push the head from below and I will pull from above. Backward and maneuver. Delivery of the shoulder first, then buttocks, then legs, lastly the head. Fourth one is forceps delivery, and the fifth one is devices. Lifting the head from below by devices to ease the delivery of the head from the above.
Any other method?
Bridge
They use
extraction.
non-dominant hand. Use of non-dominant hand.
دي pull, yes, this is
بطلع
pull method, but not dominant hand.
like any
Bridge.
other one? Bridge, reverse bridge extraction.
Bridge extraction.
Reverse bridge extraction. Okay. So you have the push method, and the push method is pushing through the vagina. Pushing through the vagina either by assistant hand or by other devices. The devices دي هي fetal pillow. Have you seen the fetal pillow ever? Anyone saw it or use it?
No.
I know في ناس كتيرين ما بحبوها, they don't like it, لكن
Ventus يا عوض. Ventus.
لا, fetal pillow. اسمها fetal pillow. I will show you the photo.
Okay.
في ناس كتيرين they don't like it, أو actually هم مش they don't like it, هم في ناس مشكلتها إنه they don't know the technique of using it. Me myself, I use it in almost all second stage cesarean section. If the head is deeply impacted, I use the fetal pillow, especially if there is extension, لأنها it aids the flexion أكتر من only pushing. It aids the flexion. It is very easy و simple technique, لكن it needs someone to be trained on it. طيب, the pull method is the reverse bridge technique. طبعا ال push method دي it's could be combined with use of the non-dominant hand اللي هي left hand إذا كنت right handed, or right hand إذا كنت left handed, and you're standing on the left side of the patient. في ال backward method التكنيك اللي هي this is the shoulder first technique and then the rest of the body using simple devices اللي هي دي fetal disimpacting system اللي هي دي fetal pillow, or extraction of the fetal head with either vacuum extractor or forceps extractor. mainly الفورسبس طبعا, one blade of the forceps واللي هو اللي اسمه الميرلس head extractor forceps. The fetal head, the push method اللي هي the fetal head extracted following pushing through the vagina assisted from below by another person or self, and is hence referred to as the push method. هي actually في الحقيقة push and pull together. هي ما push alone. يعني you push and you pull. طيب, the most important one that the one who is pushing لازم يكون هو نفسه knows how to push, and sometimes you need to do it yourself. Or if you are doing the cesarean section in a presence of someone senior, like consultants or associate consultant who is expert, they are the best one to do the push for you, because they will know how to push, because it's not only the push, it is a flexion as well. So they need to know that they need to flex the head and to push up while you are pulling from above. And the best thing is to use your non-dominant hand. Why it is important, it is helpful to use the non-dominant hand? Why it is advised?
To prevent the extension.
كيف, how it prevents extension?
Because the non-dominant sorry, تفضل.
اوكي اتفضل اتفضل.
Non-dominant hand,
okay.
less power. So no power to the lower uterus and no extended tear.
Is it?
Non-dominant hand.
Uh-huh.
Non-dominant hand hold on the lower uterine segment can lead to extensive or more tear. The dominant hand.
أيوة. The
And
dominant.
non-dominant. Okay.
Yeah, you are right. لما نستعمل الرايت هاند اللي هي الدوميننت هاند أو الرايت هاند will be the pressure will be on the lower lip of the incision. Furthermore, الموفمنت لما نستعمل الدوميننت هاند الموفمنت at the wrist joint. And at this time, while you are trying to push the head of the baby upwards, then your hand and your wrist will rest on the lower lip of the incision. وده بيخلي إنه lower lip will be extended down. فالextension بيحصل downwards. والextension downwards is very serious. أحسن ليه يحصل الextension upwards definitely. I don't want it to go downwards. أول حاجة it will go down to the area that is deep in the pelvis that is not reachable for suturing. One. Number two, it might reach to the cervix. And what is there in the cervix? It is the area of the uterine artery coming. Not only this, but injuring the uterine artery, trying to suture and to grasp that uterine artery bleeding, you are just above the ureter. And injury and ligation of the ureter is very common. If it happened, the extension is very deep and reaching to the cervix. تمام؟ The idea is why we are using the non-dominant hand. The non-dominant hand الموفمنت على الالبو joint ما على الريست joint. while الدوميننت لما نستعمل الرايت هاند الموفمنت على الريست. عشان كده الانجري والبريشر على اللور ليب بيكون more. The lower lip of the incision usually the most thin and the most weak area. ما زي الupper lip دايما لأنه upper lip you go towards the upper segment of the uterus. والupper segment is more muscular and more stronger. تمام؟ طيب في precautions before delivering the head of the baby. الprecautions شنو؟ while doing the second cesarean section.
Firstly, before opening the uterus نعمل dissection للبلادر.
Okay.
Okay, we open في upper part of the lower segment.
You open as high as possible in the lower segment.
Yes. Then we open by smile. بعمل الاكستنشن بالسيزر. بعد ذلك باخد before الأوبن ممكن أخد اللي ستيتش في اللور سيجمنت. وبعمل الاكستنشن بالسيزر.
Yes. So these are the steps that you need to follow before starting delivering the baby. Okay, so dissect the bladder as lower as possible. Push it gently low. The lower segment usually is taken up and it is high. So open as high as possible in the lower segment. حتى لو فتحت فوق مع بداية upper segment. Okay, as high as possible. وطبعا the problem is opening as high as possible. إنه extension if you go and you manipulate the head, pulling the head without pushing it from down بيعمل لك more tears. الidea ذاته إنك to open high is إنه even if extension happens, you will see the extension. Not like if you are opening low, you will not be able to see the extension and you will not be able to grasp it and suture it. So you open as high as possible in the lower segment and use the non-dominant hand, use the scissor to open the uterine cavity. And I don't know, but I usually almost always using the scissor to open the uterus rather than extension by fingers. and open as high, use the Caesar, smiling, and then try to deliver the baby. طيب اتكلمنا عن ال non-dominant hand وال push from down. Another method is the reverse breech extraction, and many people this is very favorite for many people. They think that it is safer, they will just go and grasp the limbs, the lower limbs and the feet, and bring it out. What is the difficulty? What is the technical difficulties in this?
Deeply engaged head.
Deeply engaged head. وهو
Macrosomic baby.
عشان كده أنا عملت breech extraction.
Macrosomic baby.
اوكي. تكنيكال وانت شغال كده حتى البريتش ده عايز تجيب البريتش which is very difficult. ما قادر تجيبه. 200.
Occipito-anterior يا وصل.
Occipito-anterior, yes, because the back will be anterior and the breech is posterior. مش كده اللمس قاعدة posteriorly. So you need to go behind and you grasp and you rotate the baby while you bring it. So the back anterior, this is the technical difficulty. Another technical difficulty إنه no liker. عادة second stage cesarean section, the membranes are ruptured and the most of the liker is drained already. There is no enough liker. عشان كده the space for any manipulation or movement is difficult. For breech extraction, reverse breech extraction is not always should be a favorable one. لأنه sometimes you will not be able to grasp. Plus, injuries to the foot and fracture of the femur and ankle dislocation is more in this procedure. لأنك أنت بتلف وبتقاوي عشان you rotate and you bring the baby out by the breech extraction. الباتوا method اللي هي shoulder first described by Dr. Batwartan. When incision is made in the lower uterine segment, shoulders are present usually at incision level in deeply engaged head. So the anterior shoulder is delivered out by hooking the arm. With gentle traction on this shoulder, the posterior shoulder is also delivered out. Next, the surgeon holds the trunk of the baby gently with both thumbs parallel to the spine, and with fundal pressure given by assistant, the buttocks are delivered followed by legs. Now the baby's head, which is the only part of the fetus which is still inside the uterus, is gently lifted out of the pelvis by making an arc. So here it's like delivering like in the shoulder dystocia, like it is opposite. So you deliver the anterior shoulder first, you rotate, طلع على anterior shoulder. In most of the cases where the head is deeply impacted, when you open your incision, you will find you are just above the shoulder or you are just at the level of the shoulder. So what you will do, just hook anterior, get the two shoulders out, then get the buttocks out, and then the legs. So the baby is as if you are doing the breech extraction, but you started from the shoulder. Okay? Once you hold all the body is out, then the only remaining is just the head, and you just put your the same way as you are delivering a head in a breech. You just put your two fingers around the neck of the baby, pull gently, and pull the head out of the deep pelvis. This is the fetal pillow, what I am talking about. أنا بحبها جدا. This is one of the things that I like it very much. This is the fetal pillow يا جماعة. It's just simple idea. It's just like a balloon, foldable. دي folded. ممكن التاني you can press it. Okay. ودي الانفليشن، ده المكان بتاع الانفليشن. And usually you inflate it by 180 ml of saline. Okay, so where I will put this part should be put posteriorly as a posterior fornix behind the head. يعني مش بصل بس بداية الهيد كده وبخطها. This is one of the things that people the mistakes that people they do usually. إنهم they just reach the head, the leading part of the head, and they put the fetal pillow. And in this case, what will happen? Once you inflate, الفيتال pillow هي اللي بتنزل, لكن it will not be succeed to push the head up. But you fold it, you insert it deep in the posterior fornix behind the head, and then you start inflating. Okay? You keep your hand controlling it until you start the inflation of the first 60 ml. لو شايفين السيرنج دي دايما بتيجي معاها this syringe, وthis syringe بتشيل 60 ml of saline. You fill it 3 times, تبقى 180, and then once it's become 180, you will feel yourself that the head is moving away from your fingers. يعني انت بتكون مثبتة كده زي لما نعمل الفاكيوم. You put it inside as a posterior fornix, keep it holding it, and start inflation. And then you will see the head is moving up. Okay, this is one of the things that will aid the delivery of the head. Forceps, this is the forceps, one blade of the forceps. This is a special forceps for the delivery of the cesarean during the cesarean section. You insert it gently through the incision and keep it below the head, and then you start gently pulling the head up. And sometimes في ناس بيكونوا الhead is apparent ظاهر لكن ما قاعدين to bring it. They can put a kiwi vacuum and they pull it away. Follow up. Post-operative is very important. You need to be very careful not to have any extension. You will not breathe. هتكون عامل كده زي البيبي ده. Not breathing until you check the full incision and look for any extensions. There is extensions or no. Okay. طيب, if there is extension, further management after you deliver, our further technique after you deliver the baby, deliver the placenta, check for any membranes or anything. You suture your uterine incision in 2 layers. تمام. If there is extension, what are you going to do? How are you going to tackle the extensions? You deliver the baby. ممكن تكون الستيشن. يلا, tell us, what are you going to do? You had a second stage cesarean section. Then the scenario will go, the questions will go like this. What you will do to deliver, how you will do. Okay, you deliver the baby safely. There is PPH, you manage the PPH, you give her everything, and you start suturing. Then you discover a deep extension on the right side.
طيب, firstly I will call the senior. Prepare blood if not prepared first, because I will anticipate hysterectomy. Then I will identify the apex of extension. Put stay suture or by forceps at the tip of the extension, and start to suture.
Okay.
Take 0.5 inch above the stitch. Then I do continuous suturing. After that, I will explore if there is any extensions of broad ligament and near structure and so on.
Okay. What else you will do?
Document the finding.
لسه ما
Good
قفلنا.
post-operative.
are still inside. ما قفلنا.
We have to check for a cervical canal before the closure of a uterine incision.
check اليورين the color of the
check
urine.
the posterior
Excellent.
wall of the uterus.
سلام. Thank you so much. دي منو اللي قالت check the color of the urine؟
إسراء.
إسراء. Thank you so much يا إسراء. This is the thing. This is the most important thing. At this point, when you have an extension to one side, you immediately ask your assistant or the theater attendant to check for the color of the urine. طيب, the color is blood stained. What are you going to do?
طبعا المش البروبلم يا بوس انه الاكستنشن احنا انه في المكان ده انه ممكن يحصل اكستندد لحد اليوتراين ارتري اللي هو في الرايت يوتراين ارتري او كان في الرايت سايد.
ايوه.
والخطر ايوه الحاجه الخطر في الحته دي انه ممكن اليوتراين ارتري واليوريتريك ارتري واليوريتر الرايت يوريتر.
اوكي.
فنحن نعمل تشيك انه نحن اليورين اذا كان ما ستين، ولا نتاكد انه ما ضرب الرايت يوتراين ارتري. فاذا الاثنين دول كويسين نحن بنعمل سوتشر، بنعمل نوتس بعد الاكستنشن، حتى بعد ذاك نحن بنخيط يا بص.
اوكي. safety, what are the safety measures؟ خلاص this is the extension. Extension is deep on the right side. وبعدين if you cannot reach the end of the stitch, you just put a stay suture and you go behind until you reach, and you pull gently until you reach the tip of your extension. If it is not reachable, ممكن تكون وصلت لحد السيرفكس والفاجينا down to the vagina. Then at this point طبعا you need to call a second on call, you do exploration, you try to close from there. لكن at some point you might need to do proper dissection to see the ureter and keep it away. Number one. Number two, if the urine is blood stained, what are you going to do? You are away from the angle. You are sure you did not injure the ureter, but the blood stained urine.
exploration للبلدر.
What I will do? كيف أعمل
أشوف البالون يا بوس، البالون بتاع الكاسيتر.
Okay. Palpated. It is inside.
Yes.
call the urologist.
نعمل saline through الكاسيتر عشان نشوف.
بنعمل شنو through the catheter؟
to inject نعمل تيست بإنه ندي normal saline من الكاسيتر.
normal saline ده معناه لون اليورين أو كمان أكثر.
لا ما إذا if we inject بعد ذاك جاني يعني
You have the idea يا سارية، لكن it is not the correct answer. The idea yes is to inject. What you will inject?
Methylene blue.
Methylene blue test. You have to check at this point if there is blood stain. You have to ask them to check for the urine. If urine is blood stained, you do methylene blue test. Methylene blue test will tell you if there is bladder injury or no. تمام. If no, we still blood stained, what you will do? It is blood stained, لكن methylene blue is negative. Nothing to be done. ممكن تكون شنو؟
كنت تكون من المانيبيوليشنز.
أي حصل إيه هنا
الأوبستراكتد ليبر العادية هنا أوبستراكتد ليبر
يكون
يكون فيها blood
من غير injury.
One of the signs of obstruction. Management is keep the bladder rested, keep the Foley's catheter for 24 hours, good hydration and observation, check after 24 hours for the urine color and volume. تمام؟ Still you did not close. تعمل شنو تاني؟ ما دي check دي safety measures. Safety measures check for extension, check for bladder injury or ureteric injury, and check for any hematoma or bleeding. You put a drain. If you are not comfortable about the amount of bleeding controlled, still a patient is oozing, you put a drain, keep the drain for 24 hours. At least the drain طبعا when you keep a drain inside the tummy, it's an eye inside the tummy. Yeah? When you leave a drain, you leave your eye there. It will tell you what is happening inside. So keep a drain, close the abdomen, okay, and cover the patient with antibiotic, and thromboprophylaxis could be postponed if, I mean the pharmacological thromboprophylaxis could be postponed if there is bleeding. If there is no bleeding, طوالي she can be initiated as routine thromboprophylaxis. Allow breastfeeding as soon as possible and keep the patient under follow-up. Debrief the patient after going back on the second day about all the conditions or the situations that happened during the procedure. تمام؟ طيب. Obstetric anal sphincter injuries. This is the perineal tears. Identification is the key. أهم من how to suture is how to identify. So the proper examination, it should be with the high clinical suspicion during labor. لو patient not on anesthesia or epidural analgesia, you take her to the theater for examination under anesthesia and to confirm the degree of tear. طيب. One of the important take-home messages here, it is the anal sphincter, both of them, internal and external anal sphincters, are very small, are very, the width of the sphincter is less than 1 centimeter, both of them. عشان كده it's very important to check by rubbing in between your hands and see whether there is anal sphincter injury or not. Definitely this will be done through rectal examination. Right. You diagnose that the patient has 3rd or 4th degree perineal tear. You are not sure the degree of the tear, but there is advanced degree of tear and you want to take her for examination under anesthesia. Preoperative in the OT, you check طبعا the WHO checklist, the consent has to be written. Anesthesia, antibiotic, expert one or trained personnel to perform the procedure. You prepare your instruments. Your instruments are dissecting scissor, 2 Ellis forceps, retractors, and if it is available, the Weislander retractor is better لأنه الفايزلاندر retractor هو self-retaining retractor. It will reduce the hands at that field. It's a very narrow field. Needle holder, tissue forceps. Usually we use a tissue forceps, especially the sharp toothed tissue forceps. 2 artery forceps, small artery forceps or mosquito forceps, and stitch cutting scissor. Stitch cutting scissor. The stitches, the suture materials that you will need is Vicryl 30 and BDS suture, probably 2 or more. Okay? Fine.
Repair of 4th degree tear on model. You will now be shown repair of a 4th degree tear using a perfect.
سامعين كويس وشايفين الفيديو؟
أيوة.
Okay.
ايوه
تمام.
Built latex model. Instruments and suture material required for the repair are as follows: Weislander retractor, tooth grasping forceps, fine Mackendorf or Metzenbaum dissecting scissors, 2 Alice forceps, 2 small artery or mosquito clamps, a needle holder or needle driver, stitch cutting scissors, a Vicryl 30 suture, and 2 PDS 30 sutures. A rectal examination should be performed to establish the full extent of the injury. The Weislander retractor is inserted to aid exposure. The anorectal epithelium, commonly referred to as mucosa, appears pink. The internal sphincter appears pale white. And the external anal sphincter appears red. Also note the important landmark of the ischio-anal fat demarcating the lateral border of the external sphincter. The anal mucosa is repaired using a fine, absorbable suture such as Vicryl 3O with a small round-bodied needle. Traditionally, the anal epithelium was repaired using interrupted sutures with knots tied within the anal canal. This was particularly important when using suture material like catgut that is known to dissolve by phagocytosis, with the resultant tissue reaction increasing the risk of infection. However, with newer suture materials such as Vicryl, which dissolve by hydrolysis, this is not important, and therefore the anal epithelium can be repaired with continuous, non-locking sutures with the knots tied internally. Suturing is continued up to the anal verge and a knot is tied. The anal sphincters are repaired using a delayed, absorbable monofilament suture, such as PDS-3O. The torn edges of the internal sphincter are then grasped with Alice tissue forceps, and mattress sutures are inserted, commencing at the apex of the tear. The internal sphincter is repaired by end-to-end approximation without undue tension. No attempt should be made to overlap the internal sphincter. Single interrupted sutures can also be used to approximate the internal sphincter, but mattress sutures are preferable to minimize the risk of the suture cutting through the muscle. Same type of suture material is used to repair the external sphincter, which is also grasped by Alice tissue forceps. The end-to-end repair of the external sphincter is performed using exactly the same technique as that demonstrated on the internal sphincter. Muscle ends are approximated by insertion of a mattress suture about ½ centimeter from the torn edge of the sphincter. 2 horizontal mattress sutures are usually adequate to perform this repair. The overlap repair can only be performed when the external anal sphincter is completely divided. There is no distinct advantage whether overlap is performed from right to left or left to right, with the direction of overlap dependent on the mobility of the severed sphincter ends, as well as the left or right-handedness of the operator. In this situation, the overlap demonstrated is from left to right. The first suture is inserted through the full thickness, 1 to 1.5 centimeters from the left sphincter edge. The next step is to pass the needle into the right arm of the torn muscle. The needle is inserted from outside in, 0.5 centimeter from the right edge, passing through the full thickness of the muscle, and is then returned from inside out. The needle is then passed through the undersurface of the left arm of the external sphincter, 0.5 centimeter below the original entry point. The needle is then cut off and the suture ends grasped onto an artery or mosquito clamp. The second suture is inserted in an identical manner, 0.5 centimeter below the first mattress suture and at the same distance from the medial edge. Once the suture has been inserted, it is cut and grasped in an artery clamp. As can be seen when the sutures are elevated, optimal overlap of the external sphincter is achieved. The sutures are then tied with good apposition demonstrated. Next step is to insert supporting sutures to oppose the loose ends of the overlapped muscle. This is achieved by inserting mattress sutures commencing 0.5 centimeter from the left medial edge and then passing the needle through the right arm of the external sphincter about 1.5 centimeters from its edge. This suture does not need to involve the full thickness of the muscle. The knot is then tied and the sutures are cut short. Once again, the second suture is inserted in an identical manner to the first, being 0.5 centimeter below and at the same distance from the medial edge. It is important to note that PDS suture ends must be cut short to avoid skin penetration. After the procedure, a rectal examination is performed to confirm adequate repair.
طيب يا شباب I think this video is very nice video actually. ده الفيديو أساسا الفيديو ده أنا كنت بدرس به البرينيال ريبير من السودان في البرينيال ريبير workshop و now it is one of the videos that we are using حتى هنا في الworkshop بتاعتنا. The second video is in a real model, لكن because we don't have time, it is the same idea. Maybe I will just show you fast. أهم حاجة إنه rectal mucosa should be sutured by vicarious PO, not to be inside or outside. It doesn't matter. Now we are using the vicarious, we are not using the catheter. لما كنا بنستعمل الكاتر النوت أو الربطة الأولى it has to be inside the rectum. But now because we are using the vicarious, there is no need for that. Internal anal sphincter is closed by end to end, and the suture material is end-to-end matrix suturing, and it is by BDS. يبقى internal anal sphincter end-to-end interrupted matrix BDS. Okay, external anal sphincter, if it is fully cut, complete cut of the external anal sphincter, then the option is either overlapping or end-to-end. All the evidence base revealed that there is no difference in the outcome from the overlapping or end-to-end matrix. عشان كده, because the overlapping needs techniques or training, it is better to do it as end-to-end. طبعا إذا كانت not fully cut, not the full length of the anal sphincter is cut, you cannot do the overlapping. Overlapping أصلا ما بيتعامل إلا يكون the full length of the external anal sphincter is already torn. عشان تقدر تعمل الأوفرلابينج. Otherwise you do it end-to-end وinterrupted matrix بنفس الطريقة بتاعت الانترنال anal sphincter و use the same suture material which is the BDS. الBDS هو absorbable لكنه slow absorbable material, you need to cut it very short عشان ما تعمل injury أو ما تبقى penetrating or irritating the tissue. After you finish suturing, you do the PR and then you close your episiotomy as normal. The best thing to do is to close the skin as subcuticle or interrupted matrix. No continuous suturing for the skin يا جماعة. No continuous. الشغل اللي بنعمله ده عادي. كله تكفيل كده continuous suturing of the skin, of the perineal skin is not at all in the protocol. Shouldn't be like this. Skin, perineal skin, either sutured by subcuticle or sutured by interrupted matrix suturing. Okay. أنا حمشي.
Prepare a fourth degree monofilament suture, such as PDS 3O.
This is the rectal.
The torn edges of the internal sphincter are then grasped with Alice tissue forceps.
طبعا in reality the problem is the identification of the external anal sphincter from internal anal sphincter. طبعا the problem is the external anal sphincter is retractable, وعشان كده الديماركيشن بتاع الفات behind it you pull it. عشان كده use of the Alice forceps is very important to grasp the edges of the torn sphincter and bring it together so you can do the suturing.
And mattress sutures are inserted, commencing at the apex of the tear. The internal sphincter is repaired by end-to-end approximation without undue tension. No attempt should be made to overlap the internal sphincter.
Internal, no overlap. Overlap only for the external. وحتى في external it has to be in the full tone. External ends. Okay.
The same type of suture material is used to repair the external sphincter, which is also grasped by Alice tissue forceps. An overlap external sphincter repair will now be demonstrated. There is no distinct advantage whether overlap is performed from right to left or left to right, with the direction of overlap dependent on the mobility of the severed sphincter ends, as well as the left or right-handedness of the operator. In this situation, the overlap demonstrated is from left to right. The first suture is inserted through the full thickness, 1 to 1.5 centimeters from the left sphincter edge. The next step is to pass the needle into the right arm of the torn muscle. The needle is inserted from outside in, 0.5 centimeter from the right edge, passing through the full thickness of the muscle, and is then returned from inside out.
One of the things that is very important in the length أو زي ما قلت لكم width of the external anal sphincter or anal sphincter is very small. So you might not need more than 2 stitches يعني ما بتحتاج لأكتر من I mean يعني 2 bites. You take a 2 bites. 1 bite and the second bite and that's it. ما محتاج لخياطة كثيرة. فأنت الsphincter is very small as you can see here. This is the sphincter here. So all this is complete tone. فشايفين الويدث بتاعها is very small. It is very small. It is almost 1 centimeter. Not more than 1 centimeter. Okay? And you do it the
The
same.
needle is then passed through the undersurface of the left arm of the external sphincter, 0.5 centimeter below the original entry point. The needle is then cut off and the suture ends grasped onto an artery or mosquito clamp. The second suture is inserted in an identical manner, 0.5 centimeter below the first mattress suture and at the same distance from the medial edge. Once the suture has been inserted, it is cut and grasped in an artery clamp. The sutures are then tied with good apposition demonstrated.
Okay, this is the same, then they will continue the same as you see in the model. The post-operative care is very important. Observation for hematoma, incontinence, indwelling catheter for 24 hours. Vaginal pack plus or minus, you might not need it. Patient has to be put on antibiotics, laxatives, debriefing, and patient should allow breastfeeding as soon as possible. Psychological support is of great paramount, and contraception this should be discussed at the time of discharge. Follow up after 6 weeks, and then again after 3 months. And again, if after 3 months the patient is okay with no symptoms, you discharge her. If she's still having the symptoms, you offer her pelvic floor exercise. So after the pelvic floor exercise, you give her another 3 months of pelvic floor exercise and you see her again. If her symptoms improve, then no need for further follow-up. If her symptoms persist, you requested an endoanal ultrasound to see if there is any defect in the sphincter. Okay, you should bring the patient in the outpatient clinic to discuss the future plan. The best clinic to be the patient to be seen is a clinic, a general gynecology clinic. She doesn't need advanced urogynecologist. You just refer the patient to urogynecologist after 6 months if there is still persisting symptoms. Then you can refer the patient to urogynecology for further management. The best people to do and to repair is the gynecologist because we are seeing it most, not to bring a colorectal surgeon to repair the 3rd and 4th degree perineal tear. طبعا دكتور خالد معانا لكن what we have here it is we are more exposed to this and we know the sphincters and the vagina more than the colorectal surgeons. Okay, unless there is defect, big defect, then you can call them. Even for a buttonhole, there is another emergency what that might appear, which is a buttonhole. If there is a hole in the rectum, above the area or the site of the sphincters, still should be repaired and should be repaired in the same manner as the rectal mucosa, but you do it as 2 layers. The repair should be in 2 layers. Complications, short and long-term complications and morbidity, perineal pain, infection, dehiscence, hematoma, later on abscess, fecal incontinence and urinary incontinence are later complications. Dyspareunia, one of the common complaints of the patient after 3rd and 4th degree perineal tear. Fistula, vesicovaginal and rectovaginal fistula. If it happens, it is devastating and it is very bad sequelae. Psychological trauma, and there is what is called oasis syndrome, psychological oasis syndrome. The patient will feel depressed, will lose her dignity, and someday will develop bad ideas of the whole marital status and might lead to divorce. Medical cost and litigation, especially if the tear arises from malmanagement of at the time of the delivery or as a consequences of instrumental vaginal delivery. And this is the same slide. المفروض تشتغل البتاع دي لكن I don't know why. Okay. Is that fine with you? Too much information today. Very heavy session, but this is one of the most important thing, and I think the course will not be enough without it. Come on, you can do it. It doesn't look so much. I know the exam is coming, but with keep going, practicing, then you will achieve it, inshallah. Any question?
شكرا جزيلا يا أبوس، ما قصرتي والله.
ما قصرت يا أبوس، ربنا يكرمك إن شاء الله في ميزان حسناتك يا رب، كتر خيرك كتير والله.
Thank you a lot يا بس.
Thank you. Khalid, we can stop the recording now.
Thank you.